Assalamu alaikum. This is Dr. Omar Mansour, consultant colorectal surgeon from Al Applied University. And today the lecture will be about colorectal cancer. It's a fact that colorectal cancer is a very common cancer, and it's the second leading cause of cancer death among men and women together. Facts from the States. So about 144,000 Americans will be diagnosed with colorectal cancer annually, and up to 6 out of 10 patients, or 60% of patients, colorectal cancer deaths can be prevented if all men and women aged 50 or older are screened routinely. And another important fact is that routine colonoscopy, which leads to the removal of precancerous polyps, reduces the chance of getting colorectal cancer by about 70%. We have to know the anatomy of the colon. I think we discussed the colon in more detail in previous lectures. But the colon is the last station in the GI system, which connects the terminal ileum to the anus. The colon is made of the ascending transverse, descending sigmoid colons, and the rectum. The rectum will be treated differently when it comes to colorectal cancer. In general, the rectum is usually treated differently to other parts of the colon, and because it has different anatomy and it's a pelvic organ as well. So, removing polyps during a routine colonoscopy would reduce the cancer risk. The most common types of polyps would be, the first one is inflammatory, and they are quite common. The cancer risk in these inflammatory polyps are quite low, but some people might remove them, because the best way to know if the polyp is inflammatory, neoplastic or hyperplastic, is by removing it and sending it for histology examination. The second type is the hyperplastic, which are usually small, and they have also a low risk of cancer, and they can also be removed during colonoscopy. The other three types, which are the adenomatous, the villous, and the serrated adenomas, these types can become colorectal cancer. So the adenomatous, which is the third one down, is the most common type, and it's about 70% of the colorectal polyps. Most of them would not develop into cancers, but if they get larger, then the risk of having or developing colorectal cancer is much higher, and the treatment is by performing a polypectomy and removing this polyp endoscopically. This type is the tubular adenoma. The next type is the villous or tubulovillous adenoma, which has a higher risk of cancer, but fortunately these types are much less, and they make up to 15% of all types of polyps, colorectal polyps. And as we said earlier, if they're small, they would not have a high risk of colorectal cancer, but larger polyps would have a much higher risk of developing colorectal cancer. They can be treated endoscopically, but they need skillful endoscopists. And the last type, which is the most dangerous type when it comes to colorectal cancer, which is called serrated adenoma. They also make up to 10 to 50%, but they have about 30% risk of harboring or becoming colorectal cancer. And the other unfortunate point about the serrated adenomas is that they might be harder to detect during colonoscopy because they are usually flat polyps. So serrated polyps are the highest risk, then the villus or the tubular villus, and the lowest from the adenoma family would be the tubular adenoma. So I'll talk about the polyps again in less um, or in simpler terms. The three types of neoplastic colorectal polyps are the adenomatous or tubular adenoma, the villus or villus adenoma, and the tubulovillus adenoma. Um, the adenomatous would make up to 75%, and they make tubules. The risk of malignancy is about 5%. The villus, which are flatter than the adenomatous, make about 10% of all polyps, but the risk of cancer is much higher, up to 40%. But the different studies give us different uh, uh, malignancy risks. And the tubular villus, which is the intermediate or the hybrid between villus and a tubular, which is called tubular villus adenoma, it's a mixture of adenomatous and villus, and they make up to 15% of uh, colorectal cancer, or 15% of all colorectal polyps, and the risk of malignancy is about 20%. These are different pictures of tumors during a colonoscopy. Um, this is the carcinogenesis process where a normal epithelium on the left side of the slide, if they undergo mutations like APC, MCC, 5q deletion, and CMYC, they might become small adenomas. And a small adenoma, if it undergoes a KRAS mutation, then it might become a larger polyp. But then a larger polyp, if it goes another mutation, which is like the chromosome 17p or 18q deletion or the p53 mutation, then it might become an invasive adenocarcinoma. And if there's another deletion or another mutation, they might become metastatic. So the common colonic um, non-hereditary colorectal cancer makes up more than 80% of all diagnosed colorectal cancer. The risk factors for colorectal cancers are age, above 50, family history of colorectal cancer, one first degree relative with colorectal cancer, 60 years or younger, or two or more first and second degree relatives diagnosed with colorectal cancer at any age. So either a first degree who is young, or two or more first and second degrees at any age. Second degree means a cousin or a grandfather or an uncle. Um, Other risk factors for colorectal cancer, including personal history of adenomatous polyps, serrated adenomas, or colorectal cancer. Any patient with previous history of colorectal cancer would have a much higher risk of developing future colorectal cancer than the normal population. Patients with hereditary colorectal cancer syndromes, which will be discussed in details later on, like familial adenomatous polyposis, FAP, and HNPCC, hereditary non-polyposis colorectal cancer. And the fifth would be inflammatory bowel disease, especially ulcerative colitis or Crohn's colitis. As we discussed in the inflammatory bowel disease lecture, the more severe and uncontrolled the disease in IBD, the higher and the chronicity of that severe uncontrolled IBD, then the higher the risk of developing colorectal cancer. Number six would be social lifestyle. Smoking, alcohol, and physical inactivity would lead to higher risk of colorectal cancer. And this also goes with number seven, where dietary habits like low fibers, obesity, low fruits, less vegetables, high fat consumption, and low calcium, all of these factors would increase the risk of colorectal cancer. Number eight would be the miscellaneous causes like pelvic radiation, Streptococcus bovis, bacteria, etc., etc. These might, and acromegaly, that they might increase the risk. The distribution of the colorectal cancer, we have to know that about one third, or even a bit more than one third, of colorectal cancers take place in the rectum. And if we add the rectum to the left colon, then about two-thirds of the colorectal cancers would happen in the left side of the colon. So a left-sided colonoscopy would discover about two-thirds of the colorectal cancers. So one-third, or even a bit more than one-third, of colorectal cancers do occur in the rectum. The right-sided colon, or the ascending, would only have about one quarter, and about 10% in the transverse colon. This is an example of a polyp, which is a tubular, which has a tubular part. Okay, what are the symptoms of colorectal cancer, or CRC? Recent change in bowel habits, or RCIBH, abdominal pain, which does not go away, PR bleeding, anemia, which is usually iron deficiency anemia. So the anemia would be caused by loss of the blood in the colon. Either the blood would either be seen in the toilet, which is frank PR bleeding, or it can be occult bleeding, which is more common with right-sided uh, cancers. And loss of appetite, weight loss, and FOB positive. We have to know that right-sided colorectal cancer might be diagnosed at a more advanced stage because the right side of the colon, or the ascending, has got a large caliber, and the feces in that side are fluid, so there will be no obstruction. So the patient might complain of some weakness, some abdominal pain, but because of there's no obstruction, and usually there's no frank bleeding, then the right-sided colonic cancer can be diagnosed at an advanced stage, compared to the left side of the colon, or the sigmoid, where the feces are more solid and the diameter of the colon is less, so the patients would have more obstructive symptoms and more symptoms of recent change in bowel habits. So right-sided colorectal cancer might present with iron deficiency anemia, while the left-sided colonic cancer might present with more of change in bowel habits symptoms. This is just a diagram to summarize the um, symptoms of colorectal cancer. The diagnosis of the colorectal cancer would be by taking a history, detailed history, clinical examination, and then a colonoscopy is the gold standard for these patients. If the patient is unfit for a colonoscopy, then they might get a CT scan of the abdomen and pelvis with double contrast. Double contrast means oral and IV. Sometimes we give triple contrast, where oral, IV, and rectal contrast can be given. But there is also a new method which is called CT colonography, which is a CT scan of the colon designed to see and look at the colon in specifically. So it's only a CT colonography. It's an alternative but it's less sensitive than the colonoscopy. The colonoscopy has got the advantage of seeing the tumors, taking pictures of the tumors, and taking biopsy, send that biopsy for histology. So the gold standard for diagnosing colorectal cancers and for diagnosing polyps is the colonoscopy. The second most sensitive will be a CT colon, and then the last one will be a CT abdomen pelvis with double or triple contrast. So these are different findings on a colonoscopy. So the first one on the top left side of the screen, it's 0.5 centimeter pedunculated colonic polyp, and then on the right side of that picture, the polypectomy was done, and the polyp had disappeared, but they applied what's called a hemoclip. A hemoclip is a clip that prevents bleeding after performing any endoscopic procedure. Then on the lower left side of the screen, this is a typical picture of colonic cancer, which is localized to the colonic wall. And the last picture on the bottom right hand side is a much more advanced colonic cancer compared to the one on the left side. So the bottom two pictures, the left one is an earlier type of cancer, which is confined to one side of the colonic wall, and the right lower one is a very advanced colonic cancer. So this is just a summary of how a small polyp could progress from being a small adenoma to a larger adenoma, then a larger adenoma with dysplasia. So the dysplasia has got three stages: mild dysplasia, moderate dysplasia, and severe or high dysplasia. Severe dysplasia would be a precancerous polyp, and some authorities would consider the severe dysplasia as an early cancer stage. So the severe dysplasia might progress into an adenocarcinoma, a localized adenocarcinoma of the polyp, which is the second last polyp, and then the adenocarcinoma, which is confined to that polyp, might become more invasive and starts invading the colonic wall, which is the last polyp or the last picture on the right side of the screen. And the last one is the invasive colon. We will have a quick talk about the types of hereditary cancers. The one on the left side is HNPCC, which is hereditary non-polyposis colorectal cancer, and the one on the right is the familial adenomatous polyposis. The HNPCC, the point of mutations and single and multiple exon. Um, so in HNPCC, 40% will be MLH1, 40% will be MSH2. But for FAP, on the other side, they have no common mutations, but they'll have mostly the 5 end of the gene. Um, so in the HNPCC, there are no common mutations. 29% of MLH1 and 16% of MSH2 are missense. 80% cause premature protein truncation in classic FAP. So these are just different types of uh, syndromes which could be associated with a higher risk of colorectal cancer. The first one on the top of the list is adenomatous polyposis syndrome. The first one is APC, which causes FAP or familial adenomatous polyposis. The second gene is MYH, which can cause an MYH associated MAP. Then it's MSH2, MLH1, MSH6, and PMS2. These genes are associated with HNPCC. And then the less common syndromes are LKB1, which is associated with Booth-Jagger syndrome, PJS, and then the juvenile polyposis, JPS, which is associated with SMAD4 and the MPR1A genes. The last one is Cowden disease, which is associated with PTEN gene. Okay, so back to FAP, it's the most common. It's about the most common cause of hereditary colorectal cancer is about 1 in 10,000 individuals. The risk of cancer in the affected patient is 100%. So in this type of syndrome, hundreds to thousands of polyps would appear by the age of 16 years old, and most cancers would appear before the age of 39 if untreated, and 93% would have a colorectal cancer before the age of 50. So most patients would have colorectal cancer before the age of 50. More than 90% would also have duodenal polyps. So FAP is a high risk syndrome for duodenal and periampullary carcinoma in about 10% of the cases. So 90% of FAP patients have duodenal polyps, but 10% of the FAP patients would have duodenal cancers. So this is another summary of FAP. So the risk of cancer is about 100%. The risk of duodenal cancer is about 5 to 10%. And pancreatic cancer is 2%, thyroid 2%, gastric is less. And then also we have hepatoblastoma in children, which is also significant, is about 2%. So the screening for these patients would be for the colon is an annual sigmoidoscopy beginning at the age of 10 to 12 years, but it can be replaced by regular colonoscopies. For the duodenal risks, we'll do an upper GI endoscopy. For the pancreatic issue, after the age of 20, we might do either CT scans or ultrasounds of the abdomen. And then for the thyroid as well, we might need to do either a thyroid examination or scans as well. Was during as a resected or seen in a so this is comparison of the genes and the associated features of HNPCC and which is Lynch syndrome and the FAP. I think we discussed the genes before, where MSH2 and MLH1 are the most common genes in HNPCC. The most common cancer in HNPCC will be colorectal cancer, often right-sided, and this point has to be well known. And also, they might suffer in females from endometrial cancer. Less common cancers in HNPC will be stomach, ovary, bladder, urinary tract, kidney, gallbladder, and brain. For FAP, we said the gene is APC and it's autosomal dominant like HNPCC. So both of these syndromes are autosomal dominant. For FAP, the most common cancer is colorectal cancer. But as we said earlier, these patients can have upper GI cancers, especially duodenal and periampullary carcinomas. Then the attenuated FAP, also colorectal cancer, but as we said, this is also a right-sided cancer, usually like the NPCC. But in this type of syndrome, we don't have as many polyps as in the full-blown APC. So we might have between 20 to 100 polyps of adenomas, and is also associated with upper GI polyps and cancers. Then the last one, which is the MYH polyposis, which is an MYH gene. It's the only recessive uh, syndrome on this table. The most common cancer is right-sided colorectal cancer. Okay, so um, the characteristic differences between FAP and HNPCC. Prevalence, FAP is about 1% of colonic and rectal. HNPCC is about 5%. I think we mentioned in the previous uh, slide that FAP is the most common cause of colorectal cancer. It's the most common cause of colorectal inherited or hereditary colorectal cancer in polyposis syndromes only. But HNPCC would be much more common because HNPCC will be responsible for 5% of cases. Phenotypes. Phenotype is the physical look and outcome of the syndrome. FAP, more than 100 polyps. HNPCC, it might have few polyps or no polyps at all. The genotype for FAP is APC, and for HNPCC is DNA MMR genes mutations. Age of onset, FAP is much younger, between 20 to 25 years, but for HNPCC is 40s and above. Localization of FAP is usually left-sided and rectal, and besides some other locations. But for HNPCC and the attenuated FAP and MYH syndrome, they are all right colonic. Transformation to colonic or rectal cancer in FAP is 100%. HNPC is about 50 to 70%. So the risk of colorectal cancer is much higher in FAP. I think we discussed HNPCC earlier. So this is a comparison between the general population of different kinds of cancers and the Lynch families. So, for example, for colorectal cancer, the general population risk is 1.6% from this Finnish study, but in Lynch is about 80%. Endometrial cancer is 1% in the general population, but it's 60% in the Lynch. Ovarian is much higher, urogenital, brain, kidney, stomach, and biliary tract cancers. They're all much higher in the Lynch families compared to. Then we also can talk about the Amsterdam criteria for the diagnosis of Lynch syndrome. Okay, so the colorectal cancer screening guidelines and follow-up in higher than average risk individuals. So for familial polyposis, as we said, for FAP, the lifetime risk of colorectal cancer is about 100%, and we have to start colonoscopy during childhood or the teenage years, and follow-up intervals. Um, it's not applicable, so the most recommended um, follow-up is to just resect the colon, and this eliminates the risk of cancer almost 100%. Because, as we said, these patients they have 100% risk of having colorectal cancer. For Lynch syndrome, where the cancer risk is about 50 to 70%, um, the initiation of screening is a bit at an older age in the 20s, and then if things are okay, then we can perform a colonoscopy every 2 years. Other groups in ulcerative colitis or Crohn's colitis, the risk might increase between 10 to 20%. but the risk starts to increase dramatically after 10 years of the disease. So after 8 years of a chronic disease, we start the colonoscopy and every with random colonic biopsies. And if everything is fine, then we can do the colonoscopy every 2 years. And if there is a first degree um, relative with colorectal cancer, then the lifetime risk is similar to IBD patients. So the recommendation is about 10 years to do a colonoscopy, 10 years younger than the youngest family member with colorectal cancer. And if everything is fine, then we do repeat the colonoscopy every 5 years. But if the relative is older, more than 60 years, then we do the same 10 years younger than the youngest index family member, but then the colonoscopy might not be as the patients with a first degree relative younger than 60 years old. Other risk groups or high risk groups, personal history of colorectal cancer, then we would need to do a colonoscopy every 3 years, and then it depends on the local guidelines. And if patients have adenomas, then it depends on the type and the size of the adenoma. So the high risk adenomas would be an adenoma more than 10 millimeters or 1 centimeter with villus histology, or high grade dysplasia, or more than 3 adenomas of serrated polyps with dysplasia. So the colonoscopy would be recommended depending on the guidelines, but in some authorities would recommend a 3 yearly or 1 yearly, and then depending on the findings on the future colonoscopy. Um, to diagnose an HNPCC, it's a genetic test to confirm. You can either depend on the family history with the Amsterdam or the Bethesda criteria, but it can be confirmed by genetic testing for FAP if the patient has more than 100 adenomatous polyps and microadenomas in the large intestine. As you said, diagnosis based on polyps family history, but can be confirmed on genetic. These are the mutation types in C, and then the special clinical types of colorectal cancers, HNPCC versus FAP, and then cancers in the inflammatory bowel disease. HNPCC, as we said earlier, it's between late 30s and 40s, and they can have mucinous adenocarcinomas and high-grade tumors, and there is an increased risk of metachronous multiple primary tumors as well. HNPC accounts for about 5% of all colorectal cancers. Then the FAP, as we said, um, about 100 adenomas or maybe more, and then the carcinoma in inflammatory bowel disease. So this is the TNM staging of colorectal cancer. You have to have some idea about it, especially for the primary tumor size or the depth, where Tx cannot be assessed to 0. There is no evidence. TIS is carcinoma in situ. And then T1 is tumor invasion of the submucosa, T2 muscularis propria, T3 through the muscularis propria into the subserosa or into the non-peritonealized pericolic or perirectal tissue. And then T4 is a direct tumor invasion of organs like sigmoid cancer invading the bladder or the uterus, or a perforated cancer. The patient presents with a perforated cancer. This is a T4. Regional lymph nodes NX cannot be assessed. N0, there are no lymph node metastases. N1, 1 to 3 regional lymph nodes, and N2, 4 or more lymph nodes. And then the distant metastases, MX, distant metastasis cannot be assessed. M0, no distant metastases, and M1, there is distant metastases. So there's no M2. This is Duke's staging. A, the confined in the mucosa. B, tumor growth into muscularis propria. And B2 is through the muscularis propria and cirrhosis. So B2 is full thickness. C talks about lymph nodes. So C1 is 1 to 4, and C2 is more than 4, and then D is the distant. So this is a modified Duke's staging. The 5-year survival for Duke's is about 95%, and it goes down to less than 1% if the patient has distant metastases in Duke's D. So this is modified Duke's again. A, B1, A, as we said, the survival is more than 90%. For B1 is about 80 to 85%, B2 about 70 to 75%, and then down to D is less than 5%. And if you look at the depth of the invasion of each of them, so in A, it only goes through the muscularis mucosa, B1, muscularis propria, but not through it, B2 through the bowel wall, and C, as we said, the lymph nodes are at the bottom, they are involved. So it's a very nice diagram to summarize Duke's staging or modified Duke's staging for colorectal cancer. We just need to talk about mucinous adenocarcinoma versus the regular adenocarcinoma of the colon. In general, the mucinous type is much more invasive, and so usually you have more metastases than the adenocarcinoma. This is a circumferential colonic cancer seen on a colon. And this is just another summary of stages of colorectal cancer from stage 0, 1, and then stage 2, 3, where we have involved lymph nodes, and 4, where we have metastasis. This is also a type of treatment where we can remove the large polyp which might harbor cancer using a snare. And these are clinical guidelines for chronic cancer workup. So we might perform on the left-hand side the CA levels or carcinoembryonic antigen, which is a blood test of a tumor marker, CEA. And then we do a colonoscopy. Then a CT, chest, abdomen, pelvis, can be imperative or can be done in most cases, because we need to see if there are metastases to the chest, the liver, or to any parts of the pelvis. Then the patient might undergo surgery, and then depending on the type of presentation, on the right side of the screen, if it tells us if there is obstruction, then we might use a stent or do surgery as well. If the patient has two or more cancers, then we might remove the whole colon or remove two parts of the colon at the same time. And then after the surgery, the patient might have adjuvant chemotherapy, especially for stage 3, 1A, and for high risk uh, in stage 2, 2A. High risk means that the colonic cancer has got a high grade dysplasia or new vascular invasion or vascular invasion. So this is what stenting is all about. The cancer is obstructing the lumen, then we put a wire, a guide wire, then around it, and then the stent is expanded, opening the lumen of the and this is a right hemicrectomy where the ascending colon is removed, and then the terminal ileum is anastomosed with the uh, transverse colon. And this is a left hemicrectomy where the left colon or the descending was removed, and then the transverse colon was anastomosed to the sigmoid colon or the upper rectum. This is external beam radiotherapy for pelvic cancer, and this is and as I said earlier, we can do some endoscopic resections of colonic cancers, but this has to be done by a highly skilled endoscopist. And the evidence from picture D confirms that the cancer, after a repeat colonoscopy a few months later, that the tumor has completely different depending on the stage. If this tumor is localized, is 90%, but now it could be up to 10 to 13% with different types of therapy. This is survival by Duke stage. In A is more than 90%, but in D is less than 10%. And this is survival of colorectal cancer by TNM staging. For stage 1, it's about 99%. Stage 2 is about 88, down to stage 3, and then stage 3 is 71, and stage 4 is 13%.